Right, hello everyone. Thanks for joining today. So we'll just give it maybe another minute or so, see if anyone else joins, and then we'll get started. I reckon as we've got quite a bit of content to cover, we'll just get cracking now, and then we can share out the recordings, and if anyone else wants to join in at a later point, it'll be fine. So, welcome everyone. So this is our second session in our final series. So today's session is going to be focusing on the kidneys. So renal today, and Dr. Tess Angus has kindly volunteered to do the session. So if we just move on to the next slide. So this is a series run by Thursday 15, and it's sort of a subgroup of the MedTech teaching, which is the overall organisation. And basically we're going to be running final focus sessions for the next few weeks, trying to cover all the main areas within the sort of MLA exam, as that's what I think most medical schools are going to use to base their finals curriculums on. So hopefully it should be very relevant and very useful to your upcoming finals. So in terms of how the sessions actually run, what we'll tend to do is right at the beginning, just run through 15 MCQ questions, and you'll get 15 minutes to do these. So I think Tess will keep time and make sure you're moving on at the right time. And then at the end, we'll go through the answers and sort of the subjects related to the question. And yeah, so just keep an eye out for further sessions. We'll be posting details of those on Instagram, on Facebook, and if you sort of fill in the feedback forms, you'll get automatically notified whenever we're running a session. So without further ado, I'll let Tess take it away.
Brilliant. So yeah, hi guys, we're gonna cover kidney specifically today. I know the title of the event says renal and urology. We're going to cover urology in a separate session because we thought there was enough in the curriculum to cover just renal today. These are the topics we're going to cover. So we're going to look at sort of presenting complaints predominantly, and that will cover the conditions that are on the right. The first thing we're going to do is sort of a 15-minute timed mock, if you will. Don't worry about getting the answers right, because we're going to go through sort of explanations for all the topics. We're going to give you, I think, a minute a question. So if you just grab some paper and you can just write down your answers. Okay, so if everyone's ready, I'm going to start the timer now. So I'm not starting the timer. So we're going to go through all the questions, write down all your answers, and then we'll go through all the answers afterwards, okay? Okay, so we're going to start now if everyone's ready. Okay, we're going to move on to question 2 now.
Sorry, Tess, I've just got a question in the chat, just relevant to the question. So it
Yeah.
says here, when there is a value in brackets, is that their previous values? The question.
I'm just like, that was me explaining that that's what they need to.
Oh, okay. Right. Sorry. Oh, apologies. Sorry.
Okay, we're going to move on to the next one. Okay, question 4. Question 5. Question 5. Question 7. Question 8. Question 9. Question 10. Question 11. Question 12. Question 13, nearly there. Question 14. And finally, question 15. Okay, that was the 15 questions. Well done, everyone that tried to answer them. Hopefully there was a mixture of easier and hard ones in there. I remember in 5th year I found renal very hard, and just a tip for all these Thursday 15 talks that we give, whenever there was a topic last year that I didn't understand from one of the talks, or that I knew I wasn't able to answer questions on, I then that week would go on PassMed, read up on sort of the PassMed textbook and answer sort of 10 to 15 questions again on those topics until I was really happy that I'd sort of consolidated the learning from the talk. So now we're going to go through each question in turn, look at the answer, and then do a quick sort of topic summary after each question. It would really be great if you guys can interact in the chat. So I'll put up each question in turn and just pop what answer you put in the chat. That would be really helpful, and then we'll discuss what the correct answer is. So question 1, we've got our 68-year-old with pneumonia on antibiotics, and he's not passing urine. What did people put for treatment for this patient's reduced urine output? Any answer, doesn't have to be correct. So we've got a B, we've got an E, any other votes? Another B. Excellent. Okay. So for this question, it's actually B. So we've got to think about what's going on here. So we've got a patient that's got not passing urine. They've got known infection, possibly sort of a sepsis picture. They've got a low blood pressure. And if you look at their creatinine, before it was 81, now it's jumped suddenly up to 230. Okay, so that's an AKI is what we're looking at. And the most basic treatment for an AKI is IV fluids. The person that put E was probably thinking, well, we'll think about why E is an option later. But basically, this patient is not producing much urine. So it's not that there's a problem in the bladder. They're not producing urine. Okay. They're not sort of super septic if you look at their temperature, the heart rate and stuff. And they've only just been started on the antibiotics, plus their CRP's improved. So I wouldn't change the antibiotics right now if the inflammatory markers are improving. And we can talk about whether we just sort of hold antibiotics, dialysis or catheter in a moment. So has anyone got any idea what stage of AKI that we're looking at? I think this is a stage 1, 2 or 3. 2. Okay. Lovely. Okay, so we'll move on to the next slide. So an acute kidney injury is a rapid and sustained decline in kidney function, causing oliguria, which is a reduction in urine output, and a rise in the urea and creatinine. Okay, it can be broken into 3 stages based on how much the creatinine's increased or by how much urine output they're having. Okay, it is a good one to learn. It comes up both in OSCEs and like MCQs, and also on ward rounds. Consultants seem to love that question. The onset has to be within the last 7 days, and you usually say you have to see a sustained rise in your creatinine for 24 to 48 hours, but usually we don't sort of repeat it before we treat it. We treat the underlying cause, and IV fluids are super important, okay, or just increasing the oral hydration. We break down the causes of acute kidney injury into pre-renal, stuff that happens before getting to the kidney, renal, so intrinsic kidney problems, and post-renal, so things in the ureter, bladder, etc. Can anyone give me examples of any of these, like sort of any causes that would fit into these categories? So any pre-renal or renal or post-renal causes that anyone can think of. So someone suggested pre-renal, dehydration, sepsis, absolutely. So that was probably what was happening in question 1. Hypovolemia for pre-renal, and then someone suggested obstruction for post-renal, so that's where the catheter would come in real handy. A catheter can also just help us monitor urine output, but it's not going to, if it's a pre-renal thing like in sepsis, it's not going to treat the fact that they've got an AKI, whereas in obstructive it might help. For renal, we've got someone suggesting interstitial nephritis, acute tubular necrosis, and then we've also got pre-renal, renal artery occlusion. Excellent. Okay, we're going to move on now. So just a brief sort of reminder of what the kidneys looks like. So when you zoom down into each nephron, you've got your afferent and efferent arterioles, basically the blood supply to each nephron, and that's wound around your glomerular structure and your tubules. Okay, so stuff is filtered out of the blood into the nephron structure at the glomerulus, and then can diffuse back in to the tiny capillaries from the tubules. This is just another image showing that. And water is going to also travel in both directions. Eventually, we get our urine collecting in the collecting duct. Okay. So as you guys have said, you guys gave some really good examples of the different causes of AKI. Basically, pre-renal is anything that is going to decrease blood flow to the glomerulus. Okay, that results in decreased filtration because there's a decreased pressure gradient. So we have a raised urea and creatinine. That's because they're not being filtered out entirely, and also because urea can then be reabsorbed later on, so it's going to sort of increase it even more than it is. Okay, and then overall we get then less urine being produced. Okay, so examples are things that cause blood loss, vasodilatation, or any kind of blockage in the arteries leading to the kidneys. Okay, renal problems are problems actually in the kidneys, so that can be at the glomerulus, like a sort of a glomerulonephritis, that's inflammation, or you can get acute tubular necrosis in the tubules, or acute interstitial nephritis in the surrounding tissue around the nephron. Okay, now a way to tell the difference between pre-renal and renal is to look at the urea to creatinine ratio. In pre-renal, there's nothing actually wrong with the kidney, so its normal reabsorption of urea is going to sort of continue working. So you're going to have a lot more urea staying in the body compared with the amount of creatinine that your body's keeping. Whereas in renal, you've got a problem with the kidneys. The absorption mechanism's not working, so actually you're not going to reabsorb sort of extra urea. It's gonna stay the same as your creatinine sort of filtration rate. Okay. Your post-renal causes are anything that's causing obstruction, so stops the normal sort of relief of urine into the ureters and bladder. So you've got your luminal issues, wall inside the tubes. You've got your wall issues, mural, and you've got your extrinsic things, so things putting pressure on the post-renal system. Okay, there's also things like drugs, anticholinergics, and sometimes if someone's catheterized, it can be as simple as it being occluded by clots or something like that. So it's really good to structure your answers like this in an OSCE kind of situation. Examples of anticholinergics are things like amitriptyline and calcium channel blockers, and we're going to go more into these renal problems in a second. Okay, now we're going to move on to question 2. So what answers did people put for question 2? Okay, so we've got a suggestion of D. Someone else suggesting B. Okay. Okay. So in this case, the answer is acute interstitial nephritis, which we'll talk about in a little bit. But I just want to go through why it's not the other ones. So meningococcal septicemia would probably look very similar picture-wise, but if you look at their inflammatory markers, they're much improved. Their heart rate and blood pressure are stable. They've got a mild pyrexia, and the rash has developed several days into the sort of treatment period. It would be unlikely for them to suddenly have developed a septicemia if they're on the right antibiotics for meningitis anyway. Okay, antibiotic allergy. Not an unreasonable guess. The joint pain, the fact that they're cardiovascularly stable and the urine output make it less likely. Also the timing of the rash. So if you've never had a certain antibiotic before, your allergic reaction is most likely to happen sort of the second time you have the antibiotic. If she's been having it, he even has been having it for several days without any problem, it would be unlikely to suddenly develop an allergy, although not completely impossible. Eczema, it's not the right kind of picture for that. We'll talk about why it's not acute tubular necrosis in a second. So key things to remember here are rash, joint pain, and I think eosinophilia as well. So if we move on to the next slide, causes of renal AKI. So acute Interstitial nephritis. It's, as we said, inflammation of the interstitium, and it causes this classic triad of rash, eosinophilia, and joint pain, which is what we saw in the previous question. It's usually caused by drugs, so long-term NSAID use, penicillin, acyclovir was in the previous question, and diuretics. And then I've put some other potential causes on the slide as well. Other symptoms it can cause include hematuria, a fever, sort of confusion or other mental status changes, nausea and vomiting, swelling, and also fluid retention that causes weight gain. Okay. A similar condition, but slightly different, is acute tubular necrosis. So instead of the interstitium, the surrounding tissue, this is now the actual tubules themselves. The tubular cells die for various reasons, and that causes tubule blockage and a reduced pressure gradient at the glomerulus. Okay, causes can be ischemic, so confusingly, you can also get this in sepsis and hypovolemia, but it's a different sort of pathophysiology, and any injury to the renal vessels. And then also anything that causes nephrotoxicity, so aminoglycosides, acyclovir again, so a bit of a red herring in the previous question, lead, contrast for scans, and also rhabdomyolysis. Okay, so the things sort of to recognise in a question would be a renal AKI. So you've got that urea to creatinine ratio less than 40. And key thing to remember is these muddy brown casts that you see in the urine. So that's sort of debris from the tubular cells. Okay. And then that's very highly suggestive of acute tubular necrosis. And then the last thing that can cause a renal AKI is the glomerulonephritis. They can cause AKI, but they actually more usually present as a nephrotic or nephritic syndrome. So we're going to cover them a little bit later. Okay. Feel free to pop any questions you have in the chat. And if I don't see them, Vicky will let me know. Okay, so we're going to move on to question 3 now. So this is asking what intervention is best for this patient, as well as catheterizing them. Anyone got any suggestions of answers they might give? Okay, we've got some votes for E. Thank you, guys. Okay, someone suggested D. E again. Lovely. Okay. Mostly people are going for E, it looks like. So in this question, it's asking about interventions. It's very important to sort of see, is it asking for investigations or interventions? That's the first sort of thing to look at. I always read I would suggest always reading the actual question before you read all the paragraph. Okay. So here we've got an elderly gentleman. He's been treated successfully with antibiotics, and he's quite at risk of delirium with his dementia and his other comorbidities. If you look at his OBS, he's stable at present, so I wouldn't be restarting antibiotics. And looking at his blood pressure, he doesn't particularly need IV fluids at the moment. However, he's not passed any urine for 8 hours. Okay. So you guys can look back and figure out what AKI stage that was. And he's also had a really sort of pellet-like stool recently. So we're already thinking, seems like an AKI and maybe some constipation going on here. And his medications, you see he's on regular morphine and also breakthrough morphine. And on examination, he has suprapubic tenderness, and he has retention on his bladder scan. So we've got a patient in retention that's causing a post-obstructive AKI, and they appear to be constipated. So we're relieving the obstruction already with the catheter, but what else can we do? And the answer here is prescribing a laxative. So he might need some help with IV fluids, although he's eating and drinking well at the moment. We'd need to see his bloods for that. Definitely not going to give him lorazepam at the moment or restart the antibiotics. Cystoscopy can be an appropriate investigation for post renal AKI, but at this point we've got a more likely cause of constipation, so treating that is more important. Okay, and then if we go on, so this is question 4, and then we're going to go through question 3 and 4 together. Has anyone got any answers for question 4? What medication change would you guys make if you were faced with all of this information? Any answers, or shall I just move on to the next slide? Okay. So in this case, my recommendation would be to hold candesartan. We're going to go through that, why that is, in a moment. But again, we've got a patient who's got an AKI here. They're normotensive, so stopping the antihypertensive isn't going to actually be a problem. But they are on a lot of medications that you need to be careful with in AKI, and in 2 slides time we'll go through why this patient only needs to have their candesartan held. Okay, so if we just quickly look at this overview of treating AKI, and then we'll talk about the individual drugs. So in pre-renal, you want to treat the underlying cause, so antibiotics or transfusion, etc. And you want to increase flow to the glomerulus with increased fluid input, whether that's oral or IV. In renal, because the sort of ATN or AIN usually have a drug cause, you probably want to stop anything that's contributing, or address the cause of ischemia and ATN, keep them hydrated, and then definitely speak to the renal team. And then post-renal, so we mentioned you might want to do some examinations. PR exam is the most simple one. Can identify constipation and BPH. You might send them for a CT or an ultrasound, cystoscopy if you're suspecting malignancy, or urodynamic testing if they're having problems with their bladder voiding. The most important part of the treatment, if there's an obstruction, is to relieve it, and that might involve speaking with urology. And then you can stop any contributing medications like your anticholinergics, and make sure catheters are working properly. Okay, so you treat the underlying cause, make sure they're well hydrated but not overloaded, and you look at the medications to see if you can make them any better. Does anyone have an acronym for the drugs that you might hold or reduce if renal function is impaired? I know there's a couple of different acronyms. Does anyone have one that they use for renal drugs? Well, things to stop. Someone said DAM, yeah, so stop the DAM drugs. Ooh, DAM lad, I haven't heard of that one. I wonder if that overlaps with my one. So I know there's, stop the DAM drugs is what I've heard before. In my med school, we got taught one called Diamond, which just has a couple more drugs to consider in it. That's why I prefer it. So diuretics, you'd usually hold them, although obviously the heart failure patients present a bit more of a problem. That's because they can cause an AKI in the elderly by sort of reducing your blood volume, and they can also contribute to acute interstitial nephritis. Iodine contrast can still be given depending on the EGFR, but it needs to be done cautiously, and usually a fluid bolus is given before and after to sort of flush it out and minimize damage. Okay, that's because it's nephrotoxic. ACE inhibitors and ARBs, like the candesartan, we would hold as long as it's safe to do so. And that's because they dilate the arterioles that are leaving the glomerulus, which drops the pressure gradient. Okay, and then I've but under A, there's also aminoglycosides that can cause ATN. Now, in the question earlier, metformin was one of the options, but the EGFR, if we go back, the EGFR was 74, and we don't need to hold it if it's over 30. So that was why that one was wrong. We would hold it if it's less than 30 because there's a risk of lactic acidosis if their renal function is impaired. Opiates, if their EGFR is sort of significantly reduced, we'd switch to oxycodone, or if it's even more reduced, the palliative team might suggest alfentanil. That's because opiates are renally excreted and there's a risk of opioid toxicity, but that's less so the case for oxycodone and alfentanil. In our question, the EGFR wasn't so low that we needed to switch the morphine to oxycodone. And then NSAIDs, we hold them all because they're nephrotoxic, apart from patients that are on 75 milligram aspirin once a day. That's sort of a cardioprotective dose, and if at all possible, it's best to keep that going. Okay. Now, the reason NSAIDs are sort of problematic is that they constrict the arterioles that supply the glomerulus. Okay. And then the last D in diamond is DMARDs, so disease-modifying drugs. They probably just need closer monitoring because they have a very narrow therapeutic index and there's a big risk of toxicity with them, or that they might not work. Okay. So in the question that we had, question 4, I think it was, we only actually needed to hold the candesartan for that patient. Hopefully. Okay, so this is just another little acronym to remember NSAIDs and ACE, sort of what's being constricted or dilated. So prostaglandin dilates the afferent arterioles, and NSAIDs work against prostaglandin, so that causes constriction. The enzyme ACE constricts the efferent arterioles, and therefore the ACE inhibitors cause dilatation. That's just a nice little acronym to remember it by. So if we move on to question 5, has anyone got any suggestions of how we might treat this patient? So they're being treated for an infection on antibiotics, and they're pretty stable, but on their bloods they've got an AKI, obviously these raised inflammatory markers, and the potassium and pH, I think hopefully everyone will agree, they're out of range. In the exam, sometimes they give you reference ranges, sometimes they don't, so sort of important things like potassium, I would recommend you learn what's normal and what's not normal. Oh, you're welcome, Zain. I'm glad that was helpful. I learned that last year from these talks, so that's good. Anyone got any suggestions for question 5? I'll give you a clue. The answer is not just monitor and hope for the best. Someone suggested C. And Lara's absolutely on the money. The answer is C. So we'll go through why that is, but the important things here are looking at the pH, the potassium, and the ECG, okay, to see if we need to treat them. Now, why have they got this hyperkalemia? It's because they have chronic kidney disease. So chronic and acute kidney injury, they can both cause hyperkalemia. It's a really important condition to know how to treat because it can cause life-threatening arrhythmias, okay? Lovely, someone's even given an explanation for their answer. C, because of the potassium. Yeah, absolutely. So if we go to my next slide, I like the acronym DREAD for hyperkalemia. DREAD is like a heightened state, so high potassium, and that's just the causes of hyperkalemia. So drugs, it's really good to remember them so you can recognize them in exams. Renal failure is obviously what we're talking about here. Addison's causes raised potassium. It can sometimes just be sort of lab error, so the sample is hemolyzed. We actually had a patient literally yesterday on my ward where we had a potassium that was quite high and we started panicking. We sent another sample and it was absolutely normal. So it's just about thinking about your artifact option, and then in DKA it can be raised as well. So for the management of hyperkalemia, if I go back, this patient had a potassium of 6.3. If it was less than 6, we would monitor and think about any causes and reversing them. But as it's above 6 in this case, we need to treat. And the mainstay of treatment is giving them insulin, which drives the potassium into cells, and that's given a long side glucose so they don't become hypoglycemic. You can also consider salbutamol in the nebulized form because that helps drive potassium into the cells, and calcium rhizonium, which binds potassium and makes you sort of excrete it. If they have ECG changes or a really high potassium, 6.5 or above, you need to give them some sort of calcium compound to protect the heart from arrhythmias, as well as giving your insulin glucose and your salbutamol. The calcium can either be in the form of 10% chloride, calcium chloride, or 10% calcium gluconate, but you need different milliliters to achieve the same sort of millimoles when you're giving that. So it's really important you follow your trust guidelines. In my trust, we do 10 mils of calcium chloride, but you can also give 30 mils of calcium gluconate. You don't want to sort of underdose or overdose them. Okay. This is my trust's sort of algorithm. I appreciate it's quite small to read, not very pretty, but it sort of just tells you what to do, and the fact that the calcium rhizonium or the sodium silicate can sort of remove potassium from the body. Okay. So my next question for you guys is, what ECG changes might you see in hyperkalemia? There's more than one correct answer, so throw anything out there. Okay, so we've got some tall-tented T waves. We've got supraventricular tachycardia. Someone said a broad QRS. Some really good answers here, really good. Okay. So I've stolen some pictures off the internet. This one just shows, sort of in a very simple form, the changes you can get. So as your potassium gets worse and worse, you're going to get more changes. So you first get your peaked or tall-tented T wave, and then you could get other changes like a wide PR interval, widening of the QRS, then loss of the P wave, and then this sort of sinusoidal wave. My next slide sort of shows that in a little bit more detail. So the first thing you'll see is your tall-tented T wave. Then you lose your P waves and you get this wide QRS, and eventually you can get ventricular fibrillation. So it's not typically a supraventricular tachycardia, it's ventricular, which is understandably a little worse. And if you look at that image on the top right, it just shows how the P waves can sort of become more flat and wider and then completely disappear. Okay. I think that's everything for hyperkalemia. If anyone's got any questions, pop them in the chat, but otherwise we're going to move on. So question 6. Oh no, I lied. We have another high potassium. Apologies. So I think this is the same patient, but now he's had 3 rounds of treatment for high potassium. Okay. And the pH, if people can see, is a little bit worse. And the potassium is still considerably high. Okay. He's got a low CO2 because he's probably trying to breathe it off to reduce his acidosis. And his ECG now has changes. So what do we think we need to do now? Getting lots of D suggestions. And I would personally agree. So D, absolutely. Does anyone know the acronym that we can use to remember when we would use acute dialysis? AEIOU. Yeah, you guys know all of this. Perfect. So we don't need to cardiovert this patient yet because they're not in, a dangerous arrhythmia. They've just got the tall tented T waves. There's no point repeating the insulin dextrose. It's clearly not working. And we hope as part of this they've already had the subuteral nebulizer, so the treatment's not working. We now have persistent hyperkalemia. Okay, so the only thing we can do next is the acute dialysis. So like you guys suggested, it's the AEIOU acronym. So acidosis persistently below 7.15 would be an indication. Here we've got 7.14, so they meet that. Electrolyte abnormalities in like a hyperkalemia that's persistently, well, either above 6.5 or above 7, depending on the guidelines you look at. Certain drugs, poisoning would be an indication for acute dialysis. And if a patient's got refractory pulmonary edema or symptomatic uremia, those are also two very important indications for acute dialysis. Okay. Moving on now, we've got another patient with reduced renal function, but a slightly different history now. So this patient's generally tired, got a bit of back pain, fairly stable, and looking at their bloods, there's some changes. So what investigation would be most useful for confirming the diagnosis? I'll also accept any suggestions of what the diagnosis might be. So we've got a suggestion for C. Someone's suggesting myeloma, C. Yeah, okay. Looks like people are thinking it's a multiple myeloma picture, which is absolutely the case. So we've got tiredness, back pain, hypercalcemia, got anemia and kidney dysfunction, and also well, it's not just anemia, sorry, it's pancytopenia. Okay, so we think this is multiple myeloma. Looking at the other questions, repeating the EGFR would be for looking at sort of chronic kidney function. That's not going to help us right now, confirming the myeloma. Blood film is usually for other types of blood disorders. Serum electrophoresis is an investigation for multiple myeloma that's usually used to rule it out. So it's used as part of a myeloma screen, but you can't actually confirm the diagnosis without a bone marrow biopsy. And the CT urogram is entirely inappropriate here because this is not a obstructive cause of kidney problem. This is a picture that's consistent with multiple myeloma. Okay, so in multiple myeloma, you have this overproliferation of the plasma cells, and you end up with a large amount of a single type of antibody. It's called multiple just because it affects multiple areas of the body. And your main features you get from this are CRAB, so high calcium, renal failure, anemia, and bone pain. It's really important when you see that sort of CRAB, 4 symptoms or 4 features, that you recognize multiple myeloma, because it's quite a common one in exams. Okay. Basically, the plasma cells are crowding the bone marrow. That stops you producing your other cells. You get your pancytopenia. And then the paraproteins, the immunoglobulins, cause damage in the kidneys and activation of osteoclasts. That's how you get all your different symptoms. The initial bloods are as on the screen, so ESR and plasma viscosity in addition to the ones we already had. And then you're going to do serum protein electrophoresis and urine Bence-Jones protein test to sort of screen for it. That's looking for those abnormal immunoglobulins. And then diagnosis with a bone marrow biopsy plus imaging for bone lesions. Okay. Then treatment is with chemotherapy and transplant if you're fit enough. Okay. Other treatments can include radiotherapy for bone pain, bisphosphonates to suppress osteoclasts, and orthopedic surgery if needed. Okay. So just for everyone to remember, multiple myeloma comes up. I would say at my uni it came up most years in our OSCEs, and it's a really easy MCQ question as well. So if we move on to question 8 now. Anyone got any suggestions of what's causing the symptoms? So we've got a suggestion of E. Another vote for E. Yeah, absolutely. So we just need to look at what's going on here. So we've got what sounds like edema, tiredness, shortness of breath, which if you look at the hemoglobin could be due to anemia. Frothy urine, which is suggestive of proteinuria, and itchy or pruritus. And then in the history, there's diabetes and SLE, which can both lead to chronic kidney disease. We've got hypertension. And if you look at their EGFR, it's not sort of an acute change. It was low before when it was done and it's low now, same for the creatinine. So we've got a chronic change in your kidney function and anemia, and symptoms that are consistent with CKD. So that's why it's the most likely cause. It's less likely to be heart failure because the BNP is normal. Given the combination of symptoms, a simple lymphedema is less likely. Minimal change disease we'll talk about a bit later, but it's very unlikely in someone of this age, and with the sort of itchy and diabetic and lupus background. And yes, they do seem to have symptomatic anemia, but that doesn't explain the entire picture. So it's better described by the chronic kidney disease. So chronic kidney disease is a sustained reduction in your kidney function over at least 3 months. It unfortunately tends to be permanent and progressive. And it's diagnosed by looking at either the EGFR over 3 months or albuminemia over 3 months. So if they've had an EGFR less than 60 or their urine albumin creatinine ratio of more than 3, repeated sort of 3 months apart, and it's sustained low, that counts as chronic kidney disease. Can then be further classified, I think it's the KDIGO guidelines, into sort of different stages. I've put them up here. It's quite small. It might be worth learning for your exams, but I would learn the AKI stages first. And the colours here, so the green, yellow, orange, and red is about your, I think it's about your 5-year chance of progressing to end stage or something like that, or your mortality. Symptoms, unfortunately, patients can be asymptomatic, or they might have these general symptoms that we saw in the previous case. Okay, but it's important to be able to recognise. If you have a patient where their EGFR is declining rapidly, it's called accelerated progression. So that would be if the EGFR drops by 1/4 within 12 months, or so 25%, or by 15, like the absolute value drops by 15 or more within 12 months. Okay. So there are many different things that can cause CKD. Most sort of commonly, you've got your diabetes and your hypertension. Also certain medications, the glomerulonephritis conditions that we'll talk about in a bit, congenital things like polycystic kidney disease, and also autoimmune conditions like lupus. So the patient in the question had lupus and diabetes, so it's unsurprising they got CKD, unfortunately. We'll cover these individual causes in a moment, but first we're going to talk about sort of managing CKD and what complications can arise from CKD. Okay, so you're going to look at their urine and their usinase for your diagnosis. You're going to investigate causes with a renal biopsy or ultrasound. And then you're going to look for any complications by doing various blood tests. We'll talk about that a little bit more in a second. Management, lifestyle is super important. So diet, exercise, smoking cessation can really improve outcomes. And cardiovascular disease is the #1 cause of mortality in patients with CKD. So it's really important to manage their blood pressure, their diabetes, and get them sort of generally more well, and that will help their kidney disease as well. ACE inhibitors and SGLT2 inhibitors, specifically dapagliflozin, have shown improved outcomes, and their blood pressure target is less than 130 systolic if they've got CKD. But it's really important to monitor the potassium if you start them on an ACE inhibitor. All patients with CKD should also be started on atorvastatin, okay? And eventually the patient might need renal replacement or even a transplant. So now I think, we've got some questions now, I think 2 about the consequences of COPD or complications. So if we just go through both of them, and then I've got a summary slide. So what abnormality is there in this patient's bloods, and what would you guys suggest we do about it? Okay, we've got a suggestion of C. That would be IV iron. C because of the ferritin, okay. Anyone think it's not C? Got a vote for B, okay. Feel mean because that was a bit of a trick question. The answer is C, but ultimately they are going to need B after C. Okay, so this patient has known CKD, which is consistent with their creatinine eGFR. And the other abnormality on these bloods is that they have a microcytic anemia with an iron deficiency. Now, the treatment for anemia of renal disease is the EPO injections. However, you should always correct the ferritin first. So that's why the IV iron infusion is correct here. Okay, but after that's corrected and they've got a normocytic anemia, then you would go for the erythropoietin. Okay, repeating the EGFR is pointless. We already have a diagnosis of CKD, so they're just going to have their bloods once a year. Serum electrophoresis would be for our multiple myeloma, which we don't necessarily think this patient has, and a renal biopsy would be to look at some of the underlying causes of CKD, but here we're just interested in what do we do about this anemia. Okay, moving on. Sorry, this is a slightly ugly slide. But basically, this patient who has CKD is feeling tired, a bit constipated, has muscle weakness. And the question is, what are the bloods most likely to show? In these kinds of questions, I figure out the bits I do know, and then narrow it down based on that. So if I knew that it was a high or low calcium, that would already get rid of 2 options. If I knew what I expected the vitamin D to be doing, that would also narrow it down. That can get you closer if you're not sure about the whole answer. Okay, in the interest of time, I'm going to move on. So the answer here is C, and we're going to talk about it in a second. But basically, this is a patient that has secondary hyperparathyroidism. because of their CKD. And we'll talk about why the bloods look like this in a moment. So this slide is very busy. It's just a summary of some common or important consequences of CKD. Feel free to screenshot it, or if you fill in the feedback form at the end, I think you get access to the slides anyway. But yeah, basically you've got your hypertension and edema, so you're going to treat that with antihypertensives and diuretics. Your cardiovascular disease, which you're going to do by managing your blood pressure, diabetes, and your cholesterol. If they go into metabolic acidosis, they'll need sodium bicarbonate, hyperkalemia we've talked about, anemia. The kidneys produce EPO, and in chronic kidney disease they don't produce as much, so we might have to replace that in order to stimulate red blood cell production, but iron needs to be replaced first. They may get secondary or tertiary hyperparathyroidism, and that may sort of lead on to renal bone disease or CKD mineral bone disease, which is where you get a change in your bone turnover. And that can basically be treated by reducing your phosphate intake or binding your phosphate, taking in active forms of vitamin D because you're unable to activate it normally. And then if it's a tertiary hyperparathyroidism, you can consider parathyroidectomy. Let me just check if I wanted to say anything else. For anemia, it's best to avoid blood transfusions as they can sensitize the immune system. And if a patient then goes on to need a transplant, they're at risk of rejection. Basically, when you've got hyperparathyroidism, that's going to stimulate your osteoclasts. And if you don't have enough calcium to keep up with that, you get osteomalacia. Then the osteoblasts try and keep up with the osteoclasts and create loads of new bone, but it's not properly mineralized because there's not enough calcium, so then you get osteosclerosis. And then osteoporosis can exist sort of in tandem with renal bone disease, which would need bisphosphonates, but it's not part of the sort of syndrome. Okay. The other thing is if you're in end-stage renal disease, as well as renal replacement therapy, etc., you need special dietary advice. But that's sort of beyond this talk today. So if we look very sort of specifically at your parathyroid hormone now, this is a topic I have to relearn every time I look at it. It drives me around the bend. But essentially, normally when you've got low calcium, that stimulates your parathyroid hormone to increase levels, and in response to your parathyroid hormone you get increased bone turnover, releasing calcium from the bones. You get increased calcium reabsorption in the kidneys and phosphate excretion, and you get increased absorption of both calcium and phosphate in the gut, which all works to raise your calcium. And when you have raised calcium, that gives negative feedback to the parathyroid hormone and reduces the levels. That's when it's all working. In primary hyperparathyroidism, you have, for some reason, you've got this raised parathyroid hormone. It's usually due to an adenoma. And because your sort of system's working, that causes raised calcium and low phosphate. Okay, but the parathyroid hormone is sort of being produced separate to the system. It doesn't listen to feedback. In secondary hyperparathyroidism, you've got low calcium. That could be because of your chronic kidney disease, or that could be due to just a vitamin D deficiency. So vitamin D helps you absorb calcium and phosphate in the gut, as well as reabsorbing it in the kidneys. Reabsorbing calcium. But in chronic kidney disease, there's an enzyme sort of missing in the kidneys, or not enough of it, that activates vitamin D. So you end up with low vitamin D levels in CKD, but you might also just have it if you live in the UK. So you've got your low calcium because of your other causes. That's going to raise your parathyroid hormone in response, which will try and increase your calcium levels, but probably unsuccessfully. Okay. And then the phosphate might be high in kidney disease because the kidneys can't excrete the phosphate, or if it's just a vitamin D deficiency, it might be low because you're actually able to excrete lots, and that's stimulated by your parathyroid hormone. Okay. Tertiary hyperparathyroidism is when you have your secondary hyperparathyroidism for a long time, usually an end-stage renal failure, and that causes hyperplasia, so growth of the parathyroid glands. So now you have raised parathyroid hormone coming from these massive glands, and there's actually so much now it's raising the calcium, and it's also raising the phosphate because kidneys can't excrete it, and it's being absorbed in the gut. So if we go back to our question, we've got low calcium because of the CKD, stimulating high parathyroid hormone. We've also got low vitamin D because of the CKD, and high phosphate because it's not being excreted by the kidneys. I hope that made sense. This is how I understand it, so I hope it made sense to everyone else. If we move on now, so question 11 is about a patient receiving dialysis and sort of what a common side effect might be of dialysis. So all these options are actually possible side effects of dialysis, but it's about what are we sort of most likely to see. So we've got an E and we've got an A. Someone said in query infected line. Yeah. So in this patient having hemodialysis, the only option that's sort of not an option here would be Steele syndrome, because that's only seen with AV fistulas and this patient has a tunneled line. But all the other ones are an option. So the line can get infected, and you can get blood clots but this patient is on a Pixaban, so it's less likely. And disequilibrium syndrome can happen, but actually far more commonly patients just feel a bit nauseous the first time they have it. Okay. So if we move on to here, so this is just a breakdown quickly of hemodialysis and peritoneal dialysis. We use long-term dialysis for CKD stage 5, end-stage renal failure, and we choose the type depending on their comorbidities, lifestyle, and what they prefer. Hemodialysis involves a machine in hospital, and you have to come several times a week, for example, 4 hours, 3 times a week. And it's either done via a tunneled line, so a long line, or an AV fistula where they do a connection between the artery and venous supply in one arm. Okay, it's very important that patients get anticoagulation due to the risk of clots, and there's always a risk of infection with stuff going in and out of the body, of course. Steele syndrome is where there's inadequate blood flow to the rest of the limb, so the rest of the arm, distal to the fistula. So in the question, the patient didn't have a fistula, they had a tunneled line, so that was less likely. You can also get high output heart failure if you've got a fistula, because basically blood's going very quickly back into the venous system, going back to the heart very quickly, and increasing its preload, which causes over time hypertrophy of the heart. Okay. Someone else put disequilibrium syndrome, I think, as their answer, which is not a bad answer, and can definitely happen in hemodialysis. Basically, in hemodialysis, you have rapid removal of urea, which is good. We want to get rid of it, but it can happen slightly too quickly for the body, and the body does not like it. You get a shift in the osmotic gradient between the brain and the plasma, resulting in cerebral edema, which causes neurological symptoms like headache, nausea, blurred vision, confusion, usually self-limiting, but then can progress to seizures, stupor, and death. So it's really important to recognise if a patient's becoming unwell with this. Okay. Peritoneal dialysis, on the other hand, is where you use the peritoneum as a semi-permeable membrane to filter blood. So you add a special dialysis solution that has dextrose usually into the peritoneal cavity via something called a Tenchkov catheter, and then you just have diffusion of solutes from sort of across the peritoneum membrane. Okay, it can either be done overnight by a machine, sort of pushing fluid in and out. That's called automated dialysis. Or the patient can change the solution a few times a day, sort of keep it in there for a few hours at a time. That's called continuous ambulatory peritoneal dialysis. With the peritoneal dialysis, there's a risk of bacterial peritonitis, obviously, because we're introducing stuff into the peritoneal cavity. And these infections can be particularly bad because it's such a sugar-rich environment with the dialysate fluid. The most common bacteria is Staphylococcus epidermidis. Rarely you can get something called encapsulating peritoneal sclerosis, which is a thickening and fibrosis of the peritoneum. That it causes encapsulation of the bowel and can lead to obstruction. The whole thing can just fail, unfortunately. So stops working as a dialysis method, and then you have to switch to hemodialysis. The catheter can have problems, so it can be bent or leaking or not in the right place. And because of all the sugar that you're pumping in with this fluid, some of that does go into the body, although it's supposed to cause stuff to flow out. Some of the sugar gets into your blood system that can cause weight gain and erratic blood sugars. And then obviously there's the psychosocial implications. That kind of applies to both of them. It has quite an impact on your day-to-day life. Okay. So similar kind of patient. This patient's had a renal transplant because of their end-stage renal failure. And now he's having low blood pressure, abdominal pain, nausea and vomiting. And the question is, which immunosuppressant, so immunosuppressants are given after transplant, is the most likely to have contributed to his Addisonian crisis? So how do we know it's an Addison's crisis? So the symptoms, the blood pressure, the pain, nausea and vomiting, also the low blood pressure, the low glucose, and the hyperkalemia. Those are all clues. Okay, so people are suggesting D is the answer. It's absolutely the case. I probably chose the easier one of the different immunosuppressants. If we go on to the next slide, so I've just highlighted here all the features of Addisonian crisis. If we go on to here, so I've put the different immunosuppressants on this page and what common side effects they have. I would learn this for the MLA. It's a very easy, not easy, but like if you learn it, it's going to be easy to get a point on a question that asks you about immunosuppressant side effects. So as well as the immunosuppressants causing side effects like infection and skin cancer, unfortunately, and the specific ones like cardiomyopathy, gum overgrowth, diabetes, Addison's, transplant operations themselves can involve infection, bleeding, urine leak, so if the anastomosis isn't done properly, or ureteric stenosis. The transplant can unfortunately be rejected, so if that might be within minutes, hyperacute if there's an ABO incompatibility, or it might be within 6 months if there's cell-mediated autoimmunity, or it may be longer, so chronic, more than 6 months. The transplant can fail as well, so stop working. You can get electrolyte imbalances and renal artery thrombosis. So these are just key things to remember. Transplants are indicated in patients who have end-stage renal failure. It significantly improves their quality of life. And in an OSCE, they will have a hockey stick scar, as you can see in the image there, and you'll be able to palpate their kidney in the anterior abdomen. The closer a match is, the less likely they are to be rejected. That's not always possible. So we're going to move on to the sort of last bits now. Apologies. I think we're on question 13 now, so that's good. We're going to move on to causes of CKD. Okay, we've mentioned some already, but we're going to go into a few in a bit more detail now. So I haven't got a question on diabetic nephropathy, but I thought it was important to just briefly go over it. So in type 2 diabetes, you've got both the high blood sugars causing damage to the kidneys and also hypertension causing the diabetic nephropathy. Annoyingly, CKD also leads to hypertension, so then it's a bit of a cycle. The symptoms of diabetic kidney disease are no different to the sort of general CKD symptoms, but obviously in the history they'll have diabetes as their past medical history. Onset and progression of the condition can be slowed by managing the diabetes and hypertension, as well as general lifestyle changes like smoking cessation, healthy eating and exercise. So the most important thing is to treat the diabetes. But then going on, if they are hypertensive, you're going to add an ACE inhibitor. Or if they have CKD where the albumin creatinine ratio is more than 3, you're also going to start ACE inhibitors. In normal population, it would just be above 30. But if they've got diabetes, you start an ACE inhibitor earlier. Okay, and then like we said, something like dapagliflozin, an SGLT2 inhibitor, that will be started in addition to the ACE inhibitor when the albumin creatinine ratio is above 30. Diabetics should have their EGFR and urine ACR checked once a year. And in a question in the MLA, they might mention the histology changes. So you're going to have basement membrane thickening, mesangial proliferation, and then the key one to remember is Kimmel-Steele-Wilson nodules, which is basically a nodular glomerulosclerosis. Okay, I've put some pictures here, but I don't think they'd use it would be mean if they use pictures. So now I've got a question about other causes of CKD. So what do we think is the most likely cause in this case of this patient's hematuria? So she's got gross hematuria, she's had ongoing flank pain for ages, keeps getting UTIs but doesn't seem to have the symptoms of one now. Someone suggested B, which is polycystic kidney disease. Someone else has suggested IgA nephropathy. Let me go next. So she's also got a history of kidney stones and hypertension. Her bloods show a picture of CKD. She's got slightly low hemoglobin because she's had this hematuria. And she knows there's something that runs in her family about kidneys, but she's not sure what it is. And in this case, the most likely one is polycystic kidney disease. So PCKD is a genetic condition where you have your healthy kidney tissue being replaced by fluid-filled cyst. The dominant version, the most common one, is less severe. It has symptoms of chronic flank pain, hypertension. If a cyst ruptures, you get hematuria, and that usually sort of self-resolves. They can have recurrent UTIs and stones, and they usually reach end-stage renal failure about the age of 50. It can also cause things like cerebral aneurysms, cysts elsewhere in the body, mitral regurgitation, and colonic diverticuli. Patients might describe a feeling of fullness in their tummy or headaches, and you might be able to feel their kidneys because they're so large. The recessive variant is much rarer and more severe. It can be picked up on antenatal scans, often as oligohydramnios, which is reduced amniotic fluid. So the baby produces the amniotic fluid. It's basically their waste, their urine. So if there's less, it's because their kidneys aren't working. This is a common cause. They may be born with respiratory failure because their lungs haven't developed properly. They may have dysmorphic features, and they will usually have end-stage renal failure before adulthood. They might even need hemodialysis within the first few days of life. Diagnosis is with genetic testing and kidney ultrasound. So you'll see the cysts and you'll check for the genetic changes. Just briefly, it's managed in various ways. So in the dominant form, you can use a medication called tolvaptan to slow the development of cysts. And then generally pain relief, antihypertensives, antibiotics if needed. They can have symptomatic drainage, and then they may need dialysis or transplant. Genetic counselling is super important, and they should be advised to avoid contact sports due to the risk of cyst rupture, as well as NSAIDs and anticoagulants. Patients with PCKD should be screened for cerebral aneurysms using MR angiography. Okay. So we are on our last two questions. We're going to do these two together and then got an explanation afterwards. So this 5-year-old with swelling, seems quite generalized edematous, and funny looking urine with proteinuria and low albumin. What do we think this is, and B, what do we think the next appropriate step is based on our suspected diagnosis? This is a nice common MCQ, I think, in finals, like topic anyway. So someone suggested minimal change disease and that they treat with steroids. And that is absolutely the case. So we've got a child here with edema, proteinuria. Probably the funny urine is the frothy or foamy urine. They've got albuminemia because they're losing all their protein. They've got reduced kidney function. And we'll talk about why they have high cholesterol later. So the treatment for minimal change disease, this proteinuria condition in kids, is steroids. Antivirals is not the right treatment. They don't usually need IV fluids. Repeating the EGFR would be for diagnosing CKD. It's not useful right now. And a kidney biopsy would confirm the condition, but usually we treat these patients and then only do a biopsy if they're not getting better with the steroids. Okay. And question 15. So this is a young adult, shall we say, with hemoptysis and hematuria. Their observations are showing hypertension. Their urine shows blood and a little bit of proteinuria. Their bloods show what looks like an AKI. So what condition do we think this is, and therefore what would we expect a renal biopsy to show? Okay, so this person thinks it's Goodpasture syndrome, which it is, absolutely, and they think it's A or C. Fair enough. Any other suggestions? Someone suggested C. Okay, so this patient has sort of some key features of Goodpasture syndrome: the hemoptysis or pulmonary hemorrhage. You can even get in bad situations, and hematuria. Goodpasture syndrome is also known as anti-glomerular basement membrane disease. Basically, you've got antibodies attacking the basement membranes in both the glomerulus and the lungs, which is why you get bleeding in both. So if you ever see bleeding from those two together, this is a good differential, as is sort of a vasculitis picture. They've also got hypertension, proteinuria and hematuria, which is making us think it's a nephritic condition. Okay, and we're going to talk about the different histology you might see here, but in this case it's the linear IgG deposits along the glomerular capillaries. For the people that said C, so podocyte effacement is something you see in minimal change disease. Minimal change disease, the one from the previous question, that is mostly seen in children. If you look at that under a light microscope, you see no change, hence minimal change disease. But if you look at it with an electron microscope, you see this thing called podocyte effacement. So that would be for the other disease. Okay, so I'm on my last slides, I promise, then I'll let you guys go. Just a quick overview of nephritic versus nephrotic syndrome. So glomerulonephritidis is a bit of an umbrella term for a group of disorders characterized by intraglomerular inflammation. And then the nephritic syndrome has the features of hematuria, oliguria, proteinuria that's less than 3 grams in 24 hours, and hypertension caused by fluid retention. Basically, in nephritic syndrome, you have nephritis caused by immune complexes and damagement to the basement membrane, which disrupts it and allows blood leakage. Nephrotic syndrome is sort of a situation, again, many underlying causes, where the basement membrane has become permeable to proteins due to a charge barrier disruption, allowing significant proteinuria. So there's no specific I've diagnosed you with nephritic or nephrotic syndrome. They are sort of clinical pictures that have many underlying causes. Nephrotic syndrome, you have massive proteinuria, so more than 3 grams in 24 hours, causing albuminemia, so low albumin in the blood, and peripheral edema. You don't usually get hematuria. Because they're losing proteins, that includes your clotting factors, so they're at risk of thrombosis, your immunoglobulins, so your risk of infection, and these patients, the liver kind of reacts to the low albumin by starting to synthesize things, and it ends up synthesizing more lipids as well. So you can get hyperlipidemia, hypercholesterolemia, and the patient also can become hypertensive, but that's less of a that's not in the triad of nephrotic syndrome, whereas for nephritic, hypertension is one of the core features. So if we look at some causes of nephritic syndrome, the one that has blood, reduced urine output and hypertension, as well as smaller proteinuria. These are sort of the commonest ones. IgA nephropathy and post-streptococcal glomerulonephritis, they are both ones that are associated with preceding infection. The way you can tell the difference is that in IgA nephropathy, it's a recent GI or resp infection in the last 7 days, whereas post-strep GN is their infection was, a couple of weeks ago. Some people say 2 to 4 weeks ago or 2 to 6 weeks ago. Usually they both occur in sort of the younger patients, and in IgA nephropathy, of course, you have IgA deposits as well as C3 deposits, whereas in post-strep GN, if you did blood tests to look for recent strep infection, you'd have your raised anti-DNase B and anti-streptolysin O. Okay. People recover usually fully from post-strep glomerulonephritis. Moving on, crescentic glomerulonephritis, or rapidly progressive GN, is a very acute, severe cause of nephrotic syndrome. And it's named crescentic GN because you see glomerular crescents on histology, and this one also responds well to treatment. We've talked a little bit about Goodpasture syndrome already. It's usually patients in their 20s or 60s. They'll have acute kidney failure and hemoptysis because these antibodies are attacking the basement membranes. and you see the linear IgG deposits. Yeah. Alport syndrome is a cause of nephritic syndrome that isn't sort of to do with inflammation. It's a genetic condition that causes a problem with the collagen in your kidneys. It leads to a triad of poor vision, deafness, and nephritic syndrome. It's quite a sad diagnosis. And the histology shows something called a basket weave appearance. Lupus nephritis. The key points in your question is going to be the patient has lupus. And it's going to cause a diffuse proliferative glomerulonephritis. So the histology will show sort of high extra cells, thickened membrane, and lots of proliferation. Okay, and then finally, vasculitic conditions can also cause a nephritic syndrome. So things like GPA, MP, EGPA, and you'd look for the specific antibodies to diagnose them. Overall diagnosis usually requires renal biopsy to actually look at the sort of histology, and then treatment will be guided by the renal team, but often is mainly supportive, so managing hypertension, dialysis if needed, and it can involve immunosuppression as well. Yeah. And then this is my final slide, you'll be very pleased to hear. So nephrotic conditions, I've made the really important ones big here. So in children, the one to know, the most common cause of nephrotic syndrome in children that comes up in exams is minimal change disease. So these patients have the key features of nephrotic syndrome, particularly like leg, ankle, and periorbital edema. Might have general weight gain and foamy or frothy urine. And it's usually idiopathic, but it can be a rare consequence of cancers like Hodgkin's lymphoma. And under light microscopy, there'll be no change, but under electron microscopy, you get podocyte effacement. So basically, the cells that are lining the glomerulus that are supposed to sort of stop the big proteins getting through into the tubules are sort of spaced out. There's big gaps, so everything can just go through them. Okay. In adults, the most common causes of nephrotic syndrome are membranous nephropathy and focal segmental glomerulosclerosis. Membranous nephropathy usually idiopathic, and as the name suggests, it has a thickened basement membrane. It can also be secondary to malignancy or certain infections or drugs. And one key thing to remember for exams is that there will be these immune complex deposits that have the shape of a spike and dome. Don't ask me what that actually looks like, but that's the sort of terminology they'll use to describe it in exams. And then focal segmental glomerulosclerosis, histology unsurprisingly shows segmental sclerosis, and that is linked to lupus, sickle cell disease, and HIV. There's a couple more causes, less common, I popped on this slide. So membranoproliferative glomerulonephritis or mesangiocapillary glomerulonephritis. That's your patients under 30, your immune complex deposits and mesangial proliferation. Then you've also got HSP, diabetic nephropathy, which we've gone through earlier. That shows mesangial sclerosis and Kimmel-Steele-Wilson nodules. And then certain infections like HIV can also cause nephrotic syndrome. Now I believe, yeah, that is all my slides. So has anyone got any questions? Anything that didn't make sense? And please, I beg, please can you guys fill in the feedback form? It will give you guys access to the slides, I believe, and it's really sort of helpful for me and all the other speakers for our portfolios so that we can improve these talks as well for next time. Oh, well, thank you very much. That's very nice feedback. Good. Yes, I'm glad we made it to the end too. I'm sorry it was a bit longer than I'd like, but it's a meaty topic, renal. Cool. If anyone's got any questions that they think of later, they can message us on Instagram, Facebook, email, TikTok, I think we have as well. And the team can send the questions to me. But otherwise, if you guys are happy to fill out the feedback form, I'm going to leave you to your evenings. Okay. Awesome. No worries.